I'd like to welcome everybody back to Walk with the Doc. Another gorgeous day. I don't know how many we can have of these in a row, but we'll take them. We'll take them. We have a great talk for you today with Dr. Sloan. He's the guy that puts devices in your body, and he'll tell you all about that as well. Dr. Sloan has been with Central Bucks Cardiology, part of Doylestown Health, for about 13 years, and he's the guy that's going to tell us about devices that you might need in the future. Dr. Sloan?
Oh, thank you. I'll take the mic. I have about an hour and a half presentation, if you all take We'll pare it down. We'll pare it down to a short time. So thanks, Jim, for inviting me. I appreciate it. This is my first walk, and so I'm glad to be here. It's a beautiful day. I want to talk about cardiac devices, and we have a couple different cardiac devices that we implant every day at Doylestown Hospital. We have devices that treat slow heart rhythms. So if your heart is too slow, the device is a pacemaker, which sort of paces the heart or keeps the heart from going slow. And for more serious arrhythmias, for really, really super fast arrhythmias, or if we're worried that you might suffer a future life-threateningly fast heart rhythm, we have defibrillators. And those are devices that treat fast, dangerous heart rhythms. A couple years back, they added a third type of device that we can implant, and that's a device that doesn't treat slow or fast heart rhythms, but simply monitors your heart. A little small device under the skin. All it is a monitor, and it can monitor for both slow and fast heart rhythms. We're putting a lot of those, particularly to monitor the results of atrial fibrillation treatment, and also as trying to understand why patients have had a stroke. And that's this tiny little device here, which we'll pass around later. It's a little loop monitor. It literally goes under the skin. It takes about a minute to implant. The battery pack lasts 3 years, and of course it has Bluetooth, like every modern device should have. So that's one of our newer devices, a heart monitor, instead of wearing a Holter monitor or many external monitors. So that's a nice device for the right kind of patient. Sometimes when this device goes in, it leads us to find that the patient actually has a need for a pacemaker. And this is what a pacemaker looks like. This is one of the more modern pacemakers. It's a small device that goes under the skin. A wire like this would actually be threaded through the veins. All the veins, all your blood vessels in your body either go from the heart to your body or return blood to the heart. And so if we find a vein, we can simply follow the vein from wherever, and it'll eventually wind us into the heart. And so this wire can be threaded through the veins and then placed just in the heart where we want it to go. And then it is attached to the pacemaker or defibrillator to function. So this pacemaker would go underneath the skin. It's battery packed nowadays. Most pacemakers are lasting about a decade. And it will monitor the heart. If the heart is going too slow, it'll pick up the pace of the heart and it'll pace the heart. Nowadays, they all have sophisticated memory and storage, and so it can keep track of fast heart rhythms and slow heart rhythms, and then the performance of the device itself. So this is a pacemaker. The next device we might have, you can pass that around. Yeah. I'm going to keep this for a second. Yeah. Let's see, I got myself wired again here. The next device we have is a modern defibrillator, and defibrillators come, all the defibrillators are the same in terms of detecting fast heart rhythms. If the heart goes dangerously too fast, it then begins to charge up, and if the heart is continuing to be super fast, it can then deliver a big jolt of electricity to basically reset the heart. And the way I explain this is, when your computer freezes and it's no longer behaving itself, the ultimate fix is to unplug it and wait 10 seconds and plug it back in. Basically, if the heart is going dangerously too fast, what's actually happening is all the electrical signals are firing chaotically. And we basically, with a big jolt of electricity, give up on the current electrical rhythm. It's at an electrical reset. Every heart cell is electrically reset at the exact same time with a big jolt of electricity. And then typically 2 to 3 seconds later, your normal heartbeat kicks in. And that's what this device is capable of doing. It's the same thing that a paramedic carries around, a defibrillator, much like that big automatic external defibrillator, except it's been miniaturized. And this battery pack will last a decade as well. And so it's a protection from sudden death or sudden cardiac arrest. it's a pretty amazing device. One model has extra pacemakers, so that a standard one will have one wire, a simple pacemaker. It could then have an extra wire for the top chamber of the heart, and a third wire that actually goes on the surface of the left ventricle, the main pumping chamber, to make that heart pump even stronger. And the third device I have, and sort of concluding the talk about cardiac devices, is the newest defibrillator. The newest defibrillator is a little bit bigger. It's sort of newer generation. All of these other defibrillators and pacemakers have wires that have to go into the heart to deliver their energy, to make the heart go faster, or to shock the heart back to normal rhythm. And every once in a while, wires give us problems. So this defibrillator was invented. It goes under the skin like all the devices do, but its wire, which is being passed around here, that wire actually stays under the skin. It never touches the heart. And it's capable of continuously monitoring the heart and delivering all the defibrillator therapy that you need delivered. But heavens forbid, if that wire breaks or if the patient gets an infection, it's just much less likely to have a deep infection related to a device. So currently, because it's newer technology, we're reserving it for patients at really high risk for infection, or maybe a very young patient with a genetic disease who might live with their device for 50 to 60 years, and we're worried about a wire breaking over the long term. The FDA just approved the first leadless pacemaker, and so we'll even have newer toys to play with in the device world. I have maybe a minute or two to take questions before we begin our walk.
Which is worse, fast or slow?
Well, I think that it's hard to say which is worse. I mean, we want our patients to live as full and an active a lifestyle as possible. I would say in general, the faster heart rhythms are associated with a higher risk of sudden cardiac arrest, and so that's probably a little more serious. But many patients need their pacemakers to live a high quality life. So perhaps life-threatening fast heart rhythm is a little more dangerous, but pacemakers are very important as well. Yeah. Yes?
Do any of these take the place of the bypass surgery?
No. We really need the whole heart to be taken care of. So this is electrical, so this takes care of the electrical system quite well. But the plumbers still need to do their work. We still need some stents put in. We still need the valves to work well. And so the surgeons and the interventional cardiologists, we're just the electricians to make sure the heart beats. But we still need the plumbing right. We still need the valves right. So no, it's not. They're separate and not really going to take the place of other things. Good question, though. Yes.
I have a question about AFib. I understand that there's a new product out to help
Yeah, so
stroke.
So the monitor you have right there is a monitor that can go under the skin, and it can accurately keep track of the amount of AFib a patient is having, or the success of a procedure done or medications prescribed to determine. A lot of my patients don't need this extra monitoring, but for the right patient, it's really a nice extra tool to have.
It doesn't prevent.
No, the devices are not doing a great job in preventing atrial fibrillation. 5, maybe 6% of AFib patients wind up with the device, sometimes because the treatment we prescribe slows the heart down too much, so that it's part of the treatment, but it doesn't actually prevent the AFib in and of itself. Terrific. Oh, one last question, or are we done? Yes.
It's not a question, but you should title your presentation "A Pocket Full of Miracles."
Thank you.
Thank you, Dr. Sloan. Thank you. Well, I'm not a plumber and I'm not an electrician. I'm a general contractor, so the guy that gets it all together and getting guys like this to do the work too. Cardiac rehab folks, Christine, Rich, and Karen. We're going to stretch out together. Then we'll do our walk.
We're back up, girls.
Spread your legs out a little bit. We'll just lean to one side. And then the other. I think we're ready to get started.